face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Right. A very good morning, good afternoon, and good evening, ladies and gents. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge, UK, and also one of the founders of SICOT Pioneer and currently the president of SICOT. And it's an absolute honor and pleasure to welcome all of you logging into this webinar from all around the world. Now, SICOT Pioneer, as you've heard, was born during COVID as a small platform and has grown enormously over the last few years. We've certainly embraced our digital future via SICOT, and through this platform, we've done over 90 events, and we've had over 120,000 views from 110 countries around the world. So big thank you for joining in and following us as well. Now, today's webinar is focused on the management of sequelae of septic arthritis, and we've got big hitters from around the world in pediatric orthopedics actually coming to you to educate you on this. And a big thank you to the PEDS committee of SICOT and Professor Alaric Aroojis, the lead of the PEDS committee, and also Professor Mulpuri, the past president of the Canadian Orthopedic Association, who actually got the faculty together to put this program as well. Big thank you to the faculty, and I'll hand it over to Alaric and to Kish to introduce them one by one. Now, we'll try and make this as interactive as possible. So please do post in your questions. And if you can't join us today, then you can access this on our on-demand platform as well. Once again, a big thank you and hope you enjoy this webinar. Over to you, Alaric and Kish. Thank you.
Thank you very much, Vikas. Really thank you so much to SICOT and the wonderful leadership of Vikas Kanduja, Margaret Falk, and the entire team to encourage us to present these various webinars. As Vikas has pointed out, the topic today is something that is dealt with every orthopedic surgeon and is often a big problem for many of us, and that is the management of the sequelae of septic arthritis of the hip. My name is Alaric Aroojis. I'm a pediatric orthopedic surgeon from Mumbai, India, and the current chair of the SICOT Pediatric Committee. In the true spirit of collaboration that SICOT endorses, we are partnering this time with the Hip Hope Network, and we have got a wonderful range of speakers, as you can see here. The aim this time is to keep it a little different, moving away from the usual format of didactic lectures. We have tried to make this webinar more interactive. So you can see that except for a single talk, the rest are entirely case-based discussions. And as Vikas pointed out, we'll encourage all of you attending this webinar today to put in your questions in the chat box, and we'll ask our faculty to keep answering those questions as the webinar progresses. And we'll also have time at the end, hopefully, to take a few questions and a few take-home messages as well. I'm pleased to welcome my co-moderator, Dr. Kishor Mulpuri, a great friend of mine. Kishor is a pediatric orthopedic surgeon at the BC Children's Hospital at Vancouver, Canada. He's the past president of the Canadian Orthopedic Association and a founder of the Hip Hope Network. And I will ask him in a couple of minutes to explain a little bit about the mission and the vision of the Hip Hope Network. Kishor, over to you.
Thank you, Vikas and SICOT for partnering with Hip Hope Network. And thanks, Al, for putting this amazing group of inspiring leaders that I see on the panel today. And thank you, everyone, for joining. Hip Hope Network is founded with the intent that those that are interested in children's hip can come together from all around the world, so we could make advancements in children's hips so no child should suffer from the burden of hip disease and the sequelae of hip disease. The goal is localization, which is we all do whatever we do locally in our own settings, but by sharing knowledge, by working with each other, we take our impacts and our learnings globally, and global learnings, we bring it back locally. With that word of globalization. That's really the concept of Hip Hope Network. And we've had few in-person meetings, some webinars. We're quite excited to be partnering with SICOT. If you have a device, so just get your device out and follow or join as a member, spread the word. And we are going to be having an in-person session, hopefully with SICOT, in the coming years, but we'll be doing with other national meetings. So thank you for this opportunity. Looking forward to interacting with you over the next 90 minutes or so, and looking forward to learning from all of you. Thank you.
Great. Thank you so much, Kishor. Our first speaker today is none other than Professor Ashok Jahari, and I'm sure everyone in SICOT doesn't need his introduction. Dr. Johari is a pediatric orthopedic surgeon at the Max Nanavati Hospital in Mumbai, India. He has worn several hats throughout his entire amazing career. He is the past president of the Pediatric Orthopedic Society of India, the Indian Orthopedic Association, and of SICOT as well. Dr. Johari has some amazing work in post-septic sequelae. In fact, that was his thesis during his MCH in the UK. He has published several articles and chapters related to this topic, and I think there's no one better to tell us about the sequelae of septic arthritis than Dr. Johari. So, Dr. Johari, over to you, please.
Thank you, Alaric, for asking me to speak in this webinar. Greetings to everyone who has joined this webinar. I'm going to be speaking on classification of the sequelae of septic arthritis of the hip. This is very well known, that when you have delays in diagnosis or the management is not adequate, you land up with sequelae, especially for children who are growing. Here's an example of a patient who had sepsis in the neonatal period, not treated. 2 weeks passed by. The osteomyelitic lesion is very visible in the second pane. Then you have the femoral head separating off, or the capital femoral epiphysis separating off and eventually getting resolved in that last pane. So how do these sequelae occur? There is bone loss, which could be partial or complete. The figures on the left side, the first two, you can have partial loss of the upper femoral epiphysis region or metaphysis, or you could have a complete loss of the femoral epiphysis and metaphysis. You can have a dislocation or a subluxation, the figures below and the top right, or you could have avascular necrosis and growth arrest when the physis is affected. You can also get the situation where you have osteomyelitis of the femoral neck, giving rise to a fascial slip, or a pathological fracture of the femoral neck with angulation and with pseudarthrosis. In 1982, Hanka classified the sequelae of septic hips into his 4 types. Actually, there was a type 5 also here, but that's an extension of type 4. So type 1 is where there is absent or minimal femoral head changes. Type 2, deformity of the femoral head with intact physis. Type 3, where there is type 2B, where there's a fascial closure prematurely. Type 3 is pseudarthrosis of the femoral neck. Type 4, complete destruction of the capital femoral epiphysis with stable neck fragment. Type 4B, complete destruction of the capital femoral epiphysis with the unstable small neck fragment. And the type 5, which is actually an extension of type 4, is destruction of both the femoral head and the femoral neck to the intertrochanteric line with an unstable hip or a dislocated hip. I was working on this problem in 1987, and not aware of Hanka's publication, which I subsequently became aware. We saw sequelae here, and based on the different sequelae which I encountered, I put forward my classification. Femoral head was absent in type 1 or the group 1, where part of the neck is present. Then the second group, which had a complete absence of the head neck and an unstable hip. Group 3A and 3B is dislocation and subluxation. Group 4, which is a group of avascular necrosis, along with coxa vara, coxa valga, antiversion, rotational problems, all sorts of problems, femoroacetabular impingement, a very, very big group. And group 5 is that of the pseudarthrosis of the femoral neck or with slip of the capital femoral epiphysis. Choi came up with this classification in 1990. His type 1 was infection. Sequelae, 1A was hardly any sequelae, fairly normal hip. 1B was one with coxa magna. Then there was this type 2 where the sequelae were more severe. Type 2A was a coxa breva. Femoral physis, epiphysis fused. That was again a type 2A. And then you had the situation of coxa vara or coxa valga, because of this fascial involvement. Type 3, slip of the capital femoral epiphysis, where you had a coxa anteverta or a retroverta or a coxa valga or a coxa vara. And then type 4, similar to Hanka's classification, where you had a stable remnant of the femoral neck in the acetabulum, or you had an unstable hip, completely unstable hip because of destruction. Now, Follin and Milani actually came up with their classification in 2008. The A variety is where the femoral epiphysis is present. 1A was stable. The 2A was unstable. 1B was the unstable variety because the femoral epiphysis was lost. Femoral head or the femoral epiphysis was absent in the B type. So 1B was where the femoral epiphysis was not present. 2A, again, a dislocated epiphysis, but in 2B, the complete epiphysis was lost, totally unstable. So now coming back to my classification, which is sort of my favorite, we have these different groups, and these groups have a relevance to how the sequelae are caused. So if we examine the mechanisms, you have either a bone loss, dislocation or subluxation, avascular necrosis and growth arrest, or femoral neck osteomyelitis, as was pointed out by me. So if we look at group 1 and 2, the highlighted groups, damage to the upper end of the femur with a stable remnant in the acetabulum, or a totally unstable excision arthroplasty type of effect. So bone loss is partial or complete. Then you have 3A and 3B, which are dislocation and subluxation, which have no equivalent in the Hanka or the Choi classification. So because of tamponade, because of the collection in the joint effusion and the tamponade, the femoral head can dislocate out or can be subluxated. So this is group 3A and 3B. So this is what we wrote, the group of post-septic hip dislocations when the capital femoral epiphysis is present has not been described in the commonly used classifications. Now, group 4, you can have different type of damage to the femoral epiphysis. So here you have avascular necrosis and collapse of the femoral head, like happens in a Perthes disease. Or you can have a growth arrest with a coxa breva and the trochanter overgrowth. So you have a functional coxa vara. Or you have a partial growth arrest giving rise to a coxa vara or a coxa valga, similarly possible. And group 5 is where you have an epiphyseal slip, or you can have a pseudarthrosis actually in the femoral neck, or you can have these combinations, where the pseudarthrosis is more distal, or you have a slippage of the capital femoral epiphysis along with the pseudarthrosis. This is all possible in group 5. Now, looking at these classifications, their utility is for the clinical problem. And we have these 4 clinical problems of instability, deformity, stiffness, or shortening. These are the 4 problems which we encounter following these sequelae. So what are the solutions for these? Now, if you look for the classification, you have surgery for pain in the group 1, which eventually becomes painful, because the femoral head is not there and a spike of the metaphysis inside the acetabulum. In the group 2, you stabilize to improve gait by means of a pelvic support osteotomy or a Harmon or other procedures. Type 3 and 3B, where enough remnant of the femoral head is present, you relocate that femoral head or you improve the subluxation to get the femoral head inside. Now the type 4, just like Perthes, where you have a functional coxa vara or other types of sequelae, you do surgery to improve the mechanics and gait. And the type 5, we stabilize for stability at the hip joint and to improve the gait. So their management here are stated, different procedures are possible, and we shall see some of this in the case discussion. So learning points, sequelae are caused by delayed or injudicious management of the hip infection. Timing is crucial in managing septic hips. Sequelae have as their basis direct bone resorption, increased intra-articular pressure, a vascular insert, or a fascial damage. And each group of sequelae behave uniquely and have different management considerations. So thank you very much for your attention. I'll be happy to answer questions here.
Thank you very much, sir. I think that is a wonderful overview, not only of the different classification systems that exist, but more importantly, thank you for sharing your classification system, which I think is very useful because it explains very nicely the various reconstruction steps that should be done in the different types. So I think it's very useful to the surgeon because it's not just a system which classifies the sequelae, but gives you some idea about what should be done as well. So with that backdrop, I think we move ahead with the case discussions. And if there are any questions regarding the classification for Dr. Johari, I would request our audience to put them into the chat box. Dr. Johari would be happy to answer them in the chat box, or later if we have some time to discuss this further. Our first speaker about the case discussions, and you can see now we'll try and cover the various sequelae that Dr. Johari has spoken about. We have Dr. Ayesha Saeed, who's a consultant pediatric orthopedic surgeon at the Indus University Hospital, Karachi, Pakistan. And she's going to begin with a common problem that is often seen as a sequel of septic hip, which is the non-ossification. So Ayesha, over to you.
Yes, thank you very much, Dr. Alaric. And can I have the next slide, please? So this is a very interesting case. This boy, 2-year-old, presented with a limp following a neglected right hip infection. So the exact duration or the exact account of the infection that this boy had was not known to us at the time of his presentation. It was just a painless limp at that moment. So what we could see in the X-ray was that, of course, obviously, the head is kind of missing on the right side. You can partially see the neck. When you compare it to the opposite side, you can see the ossifying normal capital femoral epiphysis. As his markers were clean and there was no active signs or symptoms of infection, so we planned to do nothing further. But like here at this moment, I would like to open to the panel and know their opinion, how they would like to intervene for a presentation like this.
If I can request Dr. Johari, so since you have presented your classification, the non-appearance of the CFE isn't really a part of any classification. So Ayesha has this interesting case, and I would love to hear your comments. One, would you do any further investigations to look into what's exactly happening with this hip? And secondly, would you intervene now or at some other point in the future?
Thank you, Alaric. Basically, like this falls under avascular necrosis. There may be a transient or a more permanent avascular necrosis. This is sort of a transient phenomenon where, the ossification has not taken place. Now, if you look at this X-ray very carefully, the acetabulum is very good. It's quite a competent acetabulum, and the teardrop is a little wide, but not very wide. So I would suspect that there is a good remnant of the femoral head inside. Even more or less, it seems to be spherical, going by the shape of the acetabulum. And over a period of years, you will have this ossification happening and the femoral head coming up. If one is very keen, of course, you can do a MRI to know the situation. The MRI will tell you what is happening inside.
Great, thank you, sir. Kishor, could I ask you as well, because I'm sure this is a problem occasionally seen in Canada also, and it's often picked up early when you have a non-ossification or non-appearance of the CFE. Would you investigate this child right now, or would you just be happy to follow this child up?
Yeah, no, Al, I think this is, if the kid is otherwise okay now, I'd just follow this right now.
Great, thank you so much. So Ayesha, do you want to proceed ahead and tell us what was done?
Yeah, so actually, Dr. Johari's classification is my favorite classification too. So, of course, as he said, this is type 1. We thought and classified it as type 1 because there is an obvious loss, or you can say the absence or delayed ossification, whatever you like to put it. And if you can go further, so we started observing this kid as the senior panelists suggested, and this is 6 months down. And if you can go further, you can see that the neck is actually appearing, getting to appear more. And if we compare it to the normal side, of course, the capital femoral epiphysis of even the left side is not pretty much as visible as it should be, but relatively it's growing. And then 1 year down, we can see actually some remnants of capital femoral epiphysis reappearing. And if we go further down, in November 2016, you can actually see a nice reappearance of the capital femoral epiphysis. All this time, this kid was only observed. And then I think we have another last follow-up X-ray of April 2018. So you can see that it's almost near normal, although there's a bit of coxa vara at this moment. But this is the last most follow-up X-ray that we have of this child. So what we concluded from this case was that, if the hip is contained and the limb is resolving and there's no active signs of infection, and as Dr. Johari very clearly mentioned about the health of the acetabulum and not too widening of the teardrop, then probably observation is the way to go. And over years, this probably tends to settle down and gets as good as the opposite side.
Great. Thank you so much, Ayesha. I think that's a wonderful learning point from here. That point's exactly highlighted by Dr. Johari, that if you see some of those signs, though it looks like the head is missing, what really is happening is a delayed ossification here. And the important point that he brought up, saying that the acetabulum looks pretty good, the teardrop is nice and tight, There's not much subluxation seen. The Shenton's arc doesn't seem to be much broken. So all of these signs, what he predicted, that going forward, it's quite likely that that femoral epiphysis would appear, and maybe nothing needs to be done except to observe. So I'd like to ask Kishor right now at this point, at this 7-year follow-up, would you do anything to this hip, or would you continue to keep following this up?
Yeah, Al, I would continue to follow. I know the story is not over with this hip yet, but I see no reason why I need to do anything. I'm not sure if it's a lying down or standing X-ray, but pelvic looks well leveled, but the articular trochanteric distance doesn't look too bad, even though there's a bit of a coxa brava. I just monitor this hip.
Great, thank you so much. I think that was a wonderful case to kickstart this webinar. I think this is a common presentation, and we are often in doubt whether we need any further investigations, whether we need to intervene early or late. And I think Ayesha has brought this out wonderfully well with a great follow-up of this case. So thank you, Ayesha. We'll move forward to the next case, and I'll stop sharing so that Dr. Johari can bring in his case of post-septic coxa vara.
Okay, so this is a 3-year-old child who had neonatal infection. Well, this was in the first week of life, and he was diagnosed to have a left septic arthritis of the hip, for which arthrotomy was done, but he did not settle, and on further investigation, when an MRI was done, it picked up a psoas abscess, and the psoas abscess was pyogenic and drained down to the hip joint. And that is why a rearthrotomy was done. This was managed elsewhere, presented to me at this age of actually 2 years old. But this is a picture at 3 years, And the problem here is, what is the situation and what should we do? You can have a look at the plain X-ray. The acetabulum looks very, very dysplastic. Well, one would ask for an MRI. So there is X-ray and there is MRI. And this is open to interpretation, by the different experts. We will discuss this MRI a little later. I'll show you some more views from the MRI. The question is when to do and what to do. These are more pictures from the MRI, So I was faced with the problem of what should I be doing, for this patient? How should I manage? I think I'll open it to the panel if anyone wants to comment on this.
Rick, do you want to go? Do you want to share how you deal with it? Welcome, Rick.
No, thank you very much. It's a really interesting case, and I've certainly struggled with similar ones. I think at this age, I would really be basing on the level of symptoms the child has. I think at this stage, it looks like there's most likely total AVN of that femoral head. And in some hands, they may consider trochanteric arthroplasty. I haven't been sure of the long-term outcome of the trochanteric arthroplasty. I don't think it's, in my hands, a durable operation, and one that I'm not sure it's necessarily better in my hands than the natural history. I think some of these children will have a limp, but possibly will go throughout their childhood without much pain. And so I'd be basing this really on childhood symptoms. Leg length discrepancy will, of course, supervene maybe 5 centimeters by maturity. But if the child was doing well with a pain-free range of motion, I'm not sure any surgical intervention in my hands could improve that natural history. And it may be later on in life, something like a pelvic support osteotomy, if that child could get to 11 or 12 without too much symptoms. So I would be really managing at this stage with a shoe raise as needed, and only intervene if the child was particularly painful. And in my hands, avoid a trochanteric arthroplasty. I just haven't felt that's been a good solution in my experience. Thank you.
It's great. What about you, Daria? What would you do in Russia for this? We'll give Daria a few minutes to get her. Great. while Daria is going to come on. Gamal, do you have how would you treat this? Okay, why don't we, while they're getting their mics on, Al?
Yes, thanks, Kish. I would agree with Rick. When I'm seeing the amount of destruction on the X-ray and the MRI, I would be quite hesitant to offer anything right now. I would tend to observe this child, give him a shoe race, see how he's doing, see how that hip evolves, because at time it's better to wait and watch rather than intervene too early. But I'll be very interested to see what Dr. Johari has done.
Okay, so if anybody else wants to comment, and then I'll go ahead, Daria or Gamal, anyone. If not, then I'll go ahead.
Yeah. Thank you, sir.
Well, so I planned, we did an arthrogram for this child, and looked like this child did have, also on the MRI, there was a capital femoral epiphysis, though avascular and irregular, but small, capital femoral epiphysis. So I did a open sort of exploration, and you can see that femoral head, which is seen as the white thing in between the retractors, So that's the femoral head. That was the arthrogram picture at the time of surgery. And I took off the greater trochanter. So just like a neck lengthening procedure, we did the same thing here. So a section of below the neck at the subtrochanteric level, just as we do in neck lengthening. So on the left pane, you have the greater trochanter, which is held in the towel clip. On the right, you see the three pieces. On the extreme side is the greater trochanter or tuberosity, and then you have the neck segment, and you have the shaft segment. These three are there. So then we sort of reconstructed this whole thing and chopped off some part of the shaft to get the correct neck shaft angle. So there was coxa vara, as you saw in the earlier picture, and that was corrected. This is at surgery. This is, of course, the pre-picture, and this is the post-picture. At surgery, the trochanter was sort of put back in its position, and relative sort of neck lengthening was done here. So on the right, on the upper part of the plate, below that is the bone segment, which we had taken from the shaft. So some years later, this 6 years post-op, he developed a fair amount of rounding of the remnant of that capital femoral epiphysis which was present. Then discrepancy was tackled by means of a temporary epiphysiodesis using 8 plates, so growth modulation. The middle pane is 6 years post-operative, and that's its function. This is another year later. You can see the reconstitution of the femoral head. Yes, it is in one side of the acetabulum, but I'll show you the clinical results of this. The neck shaft angle is good. We had to keep it at a moderate neck shaft angle because of the problem of subluxation, So this is 2024 picture at 16 and a half years of age and virtually 10 years after the surgery, And this is his clinical picture. He actually he plays active football, he's a footballer. And that's his video. And on the other side is Trendelenburg test, I guess it is very good on the right, not as good on the left, but still is able to manage fairly well. Okay. So learning points is to define the problem, investigate as is necessary. The best place for the femoral epiphysis is the acetabulum. Restore your mechanics to the best possible. Rely on nature for remodeling and follow up long term, to see what happens. Of course, this child is under follow up, So about 13, 14 years of follow up I have on him. We written up our experience of coxa vara in post-septic arthritis of the hip in children, There are hardly any papers on post-septic coxa vara. And two types of coxa varas were defined. One is because of the avascular necrosis of the capital femoral epiphysis with partial or complete fascial involvement. And the second type of coxa vara is because of pseudarthrosis of the proximal femur. It could be fascial, metaphyseal, or metaphysio-diaphyseal, as is shown in the pictures on the right. So thank you very much for your attention.
That's great. Thank you, sir. That's an amazing case. Lots of learnings there. Okay. Next we have Dr. Daria Pavlova. She's a head of the Department of Traumatology and Orthopedics at Morzau Children's Hospital, Moscow, Russia. So thank you, Daria.
Thank you, dear colleagues. I'm glad that today we have opportunity to shape this case. This is a patient with spina bifida and lower paraparesis. Have periodic checkups in orthopedist, and in age of 1 year and 4 months, were taken X-ray imaging to exclude hip dislocation. After 8 months, was taken a control X-ray. Next slide, please. And we see changes in both femurs. I showed the X-ray images in the previous slide to demonstrate that at first the structure of bone is normal. We performed a hip joint puncture for bacteriological examination of the synovial fluid, and we performed a biopsy for bacterial examination of the bone and histological analysis. These manipulations were performed on both sides. The results of the study you can see on the slide. After 6 courses of antibacterial therapy, we see positive dynamics in the right side and negative on the left. After 12 months of the antibacterial therapy, we saw positive dynamics on the left side too, and decided to continue on observation. The child had persistent urinary tract infection, so we decided to continue antibacterial therapy, and after 17 months, we see this change in X-ray images. We can see, according to the Johari classification, type 2 on the right side and type B on the left. And I would like to ask colleagues what ideas they have.
Thanks, Daria. This is an excellent case. Let's focus on the left hip for now. And I'd like to ask Dr. Gamal Hosny, how would you proceed now with this hip on the left side?
Hi, Alaric. Yes. I don't know what's, it's a pseudarthrosis, so I can do valgus osteotomy and plating. And if he has shortening, we can do lengthening at the same time, it's both.
Excellent. When you do a valgus osteotomy, there is this large gap in the femoral neck. Would you bridge that with some cancellous bone or put a fibular graft across?
I don't think it's a gap. I don't believe it's a gap. There is something in between, perhaps a fibrocartilage or something. And when you change the direction of the weight bearing, I think you can change it into bone. You usually do that in the cases of non-union of the femoral neck without putting any bone in between.
Excellent. That's a great point that you have made. Let me ask Tim Nunn. Tim, would you do any further investigations? Gamal brought up an excellent point, and we see that often, as he has said, when you have a non-union of the neck or the femur, that it looks like there's a gap, but actually there's fibrous tissue. I'm not so sure in this case because, when there's infection, sometimes you could get a true destruction of the neck. Would you investigate this child further in the form of like a push-pull X-ray? Would you get an arthrogram done? Would you get an MRI done before you intervene?
I think a dynamic fluoro would be nice to see in this case. I just wanted to ask the presenter whether the child was walking. I may have missed that. Obviously it would change my approach if this was a walking child. Yeah.
So Daria, could you confirm? You said this child has spina bifida. Is this an ambulant child or is a child on a wheelchair?
Sometimes the verticalization in apparatus, and she don't go for a walk without some help.
Sure. So she's a limited ambulator.
Yes.
So Tim, would you do any further investigations then?
I think I might be rather more conservative than Prof. Gamal. I think I might see how she gets on without any intervention if she's very limited in her walking. Yeah.
Great. That's a great point to bring up because this is a child who has spina bifida, so she's also got problems with ambulation. She also has problems with osteoporosis. She also might be insensate in some areas, so that's also an important consideration. In the interest of time, Daria, why don't you go ahead and show us what you did?
Colleague said about the typical approach in these cases, and the goal of treatment of this type of sequence is osteosynthesis with correction of displacement or without bone grafting, and more commonly recommended approach with bone grafting combined with subtrochanteric valgus osteotomy. But in this case, the child has no femoral neck left, and we think that the performance of valgus osteotomy would not have been successful. And the parents want to continue verticalization in apparatus, and we decided to do next next slide, please, and the next. We repeated the bacteriological examination on the sineral fluid and the bone, and we got a negative culture. After this, we performed the operation. We resected the pseudarthrosis zone, and after this, performed the osteotomy of the femoral shaft, moved the resulting bone fragment to the femoral neck area. After this, we performed absolutely stable osteosynthesis with plate and transferred the great trochanter. So we obtained the femoral neoneck from the femoral shaft and restored the NDA. Next slide. This approach allowed us to obtain a good result. After 11 months, we complete reconstruction of the osteotomy zone, absence of pseudarthrosis of the femoral neck, and good clinical results. So after 30 months, next slide, of the operation, we removed the plate.
Great. Thank you very much, Daria. This is an excellent case, and I think it's been really wonderfully managed. We do, of course, have problems with the other hip as well, and this one also does show some residual subluxation. We understand that this is a child with spina bifida, so will not have some great muscle movements, and we need to keep the child under follow-up. Dr. Johari, sir, is there anything else that you would have done differently, or looking at the current X-ray now, is there something else that you would do?
Well, basically, like if you have a pseudarthrosis, whether there is something there or not there, what we find is they eventually tend to shrink, unless that pseudarthrosis is very, very strong, They tend to shrink. So over a couple of years, you'll find that they have really gone into a very severe coxa vara, Well, you could leave them alone up to some point in time, but you need to image them and follow them up, If the coxa vara is increasing, you would need to do surgery, and something like what has been done some form of valgus osteotomy, with or without bone grafting, would be required. So I congratulate Daria for the excellent results she has had. We would like to see the long-term follow-up some point in time. Thank you.
Thank you, John.
Thank you very much. That's again some great learning points there. We'll move ahead with the next case of Dr. Rick Gardner, and I'll ask Kishor to introduce Rick and to moderate the case, please. Thank you.
Thank you, Al. It's a real pleasure to introduce a fellow surgeon from Canada, Rick Gardner. Rick had an extensive experience of really working in 3 different continents. He trained in the UK, he did his fellowship at SICOT, then he went to Africa, and he lived there with his family for 10 years and took care of a lot of complex issues, and certainly a very inspiring person to be around and have a chat with. So with that, Rick, we're looking forward to hearing your case.
Kishor, thank you. Thank you very much. So this is a 2.5-year-old boy who was referred for a limp and a small leg length discrepancy. He had a history of hip sepsis at 1 year of age. No arthrotomy was performed. He was managed with IV antibiotics in a regional hospital, and then presented to us 1.5 years later at this 2.5-year-old with a dislocated left hip, acetabular dysplasia, X-ray showing this medial metaphyseal beak, a very eccentric ossific nucleus, abnormal morphology of that left hip, possibly some involvement of the right hip as well. But certainly one which I was wrestling with what I should do. Next slide, please. And really, should we intervene this stage? Professor Johari has really given us a huge perspective across the board of this. And I think really just that whole aspect of us needing to improve upon the natural history. I think we all enjoy operating on DDH and seeing, excuse me, the picture on the left with a nice round femoral head and ligamentum teres and an acetabulum we can put the femoral head into. But early on in my time in Ethiopia, the X-ray on the bottom right, I assumed to be DDH. I've become wiser in the years that follow. But I opened up the hip on the right and then found a very, very scar tissue planes and had that sinking feeling, finding everything was all stuck together and an obliterated acetabulum. And then to my great disappointment, seeing really a saddle-shaped femoral head, which I certainly learned from. And I think that X-ray on the far right isn't the one we're discussing for this particular case. But again, it's got an eccentric ossific nucleus, this medial metaphyseal beak, a low dislocation, all hallmarks that indicate a possible neglected hip sepsis. And just trying to avoid doing an open reduction in a case such as this, where actually we could create what is a pain-free mobile hip into one that becomes stiff and painful by an attempted open reduction in the wrong case. Next slide, please. And I think this was also another point of view challenging for me. 16-year-old who comes into clinic with an untreated infantile septic hip dislocation, totally pain-free, a leg length discrepancy that could be managed by a lengthening procedure, but actually a very flexible hip. She could squat, she walked around very well, and really just to hold up any intervention. We would do would be as good or ideally better than the natural history at a minimum. So if I could please, oh, there we go. Thank you. Just open up to the panel and just what would the panel do at this stage? Other investigations or management? Thank you.
Maybe we could start with Ayesha and then we'll move to Dr. Johari.
Yeah, a very interesting case, Dr. Gardner. I had a brief meetup with him in SICOT. So inspiring case, inspiring person, as you said. For a totally dislocated hip like this, I would certainly go But like you said, cautiously, knowing that this is a septic hip and maybe getting an MRI done, but probably this hip is out and this needs an open reduction and containment, and I would keep it in a spica so that I'm sure that, this is nicely healed and then kind of, move there. Maybe this would also require a pelvic osteotomy because there is a dysplastic element on the acetabular side.
Okay, great. Thanks, Ayesha. Dr. Johari?
Yes, I think imaging is very important here to mainly see the shape and size of the femoral head, If the femoral head is large because avascular necrosis, I may not do anything for this patient, If the femoral head is really large and irregular, But if the femoral head seems containable, and the deformity of the femoral head is not much, I would tend to go for an open reduction. What Ayesha said, we do open reduction combined with femoral and pelvic procedures,
Thank you so much. And does any of the other panelists have any other opinions? Would do anything different?
Yes, sir. I've seen the second case. This is straightforward for pelvic support osteotomy, unstable hip, and she can get benefits for pelvic support. It's a lasting operation. You don't need arthroplasty afterwards. She can squat. She can do all the job. For the second case, for this case, I think we just follow up to see what's going to happen. Is it going to dislocate more or something like this?
Great. Rick, what have you done with this?
No, thank you. So we had a series of cases similar to this, with a dislocated hip, with some presence of the ossific nucleus. There are avenues of non-operative management. The team from New York, more historical now, but really advocate for non-operative management to avoid a stiff, painful hip when the hip was pain-free. But of course, with the resultant leg length discrepancy and probably inevitable Trendelenburg gait. Next slide, please. And then Professor Johari, of course, with a really excellent paper advocating for, in the right indications, closed reduction or open reduction. And then I think it comes around to what we're talking about in the panel. Which case is the right one for an open reduction? Next slide, please. So I've done MRIs for cases like this, and I've done arthrograms. I found the MRI doesn't necessarily give you full indication of the viability of that ossific nucleus. I found arthrograms, sometimes I've misinterpreted them and seen more of an ossific nucleus than I thought was actually present. So I've come to wait for these for a year and just to see what happens and just to look for the development of the ossific nucleus. If it is growing and is continuing to show good viability, then I proceed with an open reduction. And so this one here, 2.5 years of age, the initial X-ray, then a year later, showing further growth, the ossific nucleus, something which looks a bit more like a regular DDH hip. Of course, going to be very flat medially, but a hip that I felt might do better with an open reduction. So we did proceed. Next slide, please. So open reduction, of course, very scar tissue planes, obliterated acetabulum, very careful picking out all of that scar tissue to gradually get down to articular cartilage, which was in reasonably good condition. And then a femoral shortening. I don't think I put in any derotation. I didn't need to, and an acetabuloplasty to deal with that acetabular dysplasia. And then following the child forward, showing that the hip remains stable with improvement of the acetabular morphology and a stable hip. And next slide, please. And until now, some 7 years post-op. So definitely not a normal hip, a coxa vara, some trochanteric, developing trochanteric overgrowth, maybe someone for to stop the growth of the great trochanter, or in the future, femoral neck lengthening osteotomy in the years to come. But I think in this case, probably is an improvement on the natural history, at least for childhood, creating a stable hip with a minimal leg length discrepancy, and child doing well and pain-free. But I think the aspect that I've really wrestled with is which are the cases to intervene on, and certainly some might be better off to leave for a future pelvic support osteotomy. Next slide, please. So I think for me, I've benefited from waiting a year just to see further growth of cific nucleus before making that decision. I found that to be more helpful for me than even MRI and arthrogram, and but very grateful for the perspective and being a part of this. Thank you very much indeed.
Fantastic. Thank you very much. I think in the interest of time, I think we'll move to the next case.
So the next is Gamal. So Gamal, if you can project your slides. Professor Gamal Hosny is well known again to all of us. He's an orthopedic surgeon, very interested in limb reconstruction from Cairo, Egypt. He's been the past chair of the pediatric SICOT committee, and he's got some great experience with infection and reconstruction. So Gamal, over to you.
Thanks, Alec. So I'm in the outpatient clinic. I'm working now. This patient presented to me at the age 4.5 years old. She had a history. She was in the incubator and a history of septic arthritis. She had drainage. Twice she had now limping gait, 5 centimeter shortening, no pain, and pelvic obliquity. She was referred to me to do lengthening. And this is the AP, and you see the pelvic obliquity and the frog position. I know that everybody's concerned about the hip stability. I don't know how to test it, the hip stability now, just clinically or radiographically. So do we do any intervention for the hip to increase the stability? If you want to do lengthening, do we do limb length equalization? If we do it, the timing. Timing is very important. Do we do it now, or do we wait for a few years later on or something? What would you think, guys?
So we'll open this for discussion. That's again a great case and a common scenario with sepsis. Let's ask Rick, what do you think you would do with this? One is, would you do any investigations further? Would you do anything to the hip right now, or would you straight away go for a limb length equalization?
Thank you. Professor Hosny, can I just ask how old the child is?
She's 4.5 years old.
And does she have any pain?
No pain.
Okay.
Just limping.
Just limping. So I think for me at this stage, I don't think I can do any better for that hip. The hip is in station, but is one which is there's obviously avascular necrosis. I think any intervention to improve that, I think, might just increase the contact forces across that hip and accelerate the degenerative change. So at this stage, I would offer a shoe raise at this stage and follow the child through. And then in the future, expecting a pelvic support osteotomy would be most likely the way forward, along with a contralateral epiphysiodesis. But at this stage, I would manage with a shoe raise and continue to follow.
So, Kishor, would you agree with your fellow Canadian? Would there anything else that you would do at this point?
Yeah, I think I'd definitely watch for now. I don't think I would do anything different. I definitely won't consider lengthening. Lengthening in a unstable hip like this, and with the shallow acetabulum, that hip is going to dislocate. So I think I'd definitely be waiting.
Great, thank you. Gamal, why don't you go ahead and show us what you did?
Okay. We did lengthening, and we told the family that we are going to monitor the hip. So should you have any problem, we are going to stop or to do compression afterwards, because we do gradual 1 millimeter per day. And now, work it out. And it was okay. There was no problem with the hip. And they were satisfied. Then, 2016, after 6.5 years, they came again with 5 centimeter shortening, limping gait, no pain. They want to have lengthening, more lengthening. What would you think?
So, Dr. Johari, let's ask you this. For the first lengthening itself, both Kishor and Rick brought up an important point that you have an unstable hip. And when you do lengthening, there's a risk of causing that remnant of that head to dislocate out. So would you do something protective in the form of a pelvic osteotomy, a triple or a Dega to contain that hip better prior to your lengthening? Or alternatively, would you span the pelvis while you're doing a lengthening in the first stage itself?
Yeah, two things I would have done a little differently is to do a pelvic osteotomy, Dega acetabuloplasty. You need to horizontalize the roof of the acetabulum and to do a greater trochanteric fusion, epiphysiodesis of the greater trochanter, stage 1. And then I would have considered lengthening if my hip was very stable. If the CE angle was good, then only a lengthening is required. If the hip is slightly unstable after doing all this also, the unstable, I would span the pelvis. So maybe at this stage, there may be a point in spanning the pelvis. I don't know, Gamal will tell us what he did.
Let's ask Tim before that. Tim, Gamal's been successful in his first stage of lengthening, and it's been a modest amount of lengthening that he's achieved. But as expected, there was some issues with that hip, which has now subluxated some more and is now articulating only the superior part of the acetabulum. So with these comments, would you do something further? Would you give in to the patient's demands to lengthen again? Or would you do something else prior to that?
Well, thank you. I noticed that the triradiates have closed on this, so this is much older now. And if it were possible, it would be great to do a contralateral distal femoral drill and curette epiphysiodesis at a timed moment, and to watch, because I definitely think more will need to be done on this hip, of course, in the future, on the left side, and I'm sure it will start to become painful as the child goes through their adolescence and into early adult life.
Thanks, Tim. That's a great suggestion. Doing a well-timed distal femoral epiphysiodesis of the opposite side to try and decrease that limb length discrepancy. But Gamal's, of course, the reconstruction expert, so let's see what he has done.
We did lengthening again from the distal femur. And again, we told the family we are doing gradual lengthening. So if anything happened, we are going to reverse it or whatever. I think, this is not a normal hip. We have congruous incongruity. You cannot judge it by a normal hip or something. Doesn't carry the characters of a normal hip. Anyhow, you see, we always do pelvic AP each 10 days to guard against the development of subluxation. So you see, sequentially, there is no subluxation. It's the same. And we finished in 2017. And you see the x-rays, long-standing x-rays. And she married at the age 18. In this area, they marry young, and she had 2 children. And this is 14 years follow-up. Look to the hip. It's almost the same. And she came to me because she had some pain at night. She's carrying her children and working or something. And nothing. We did nothing for her. In conclusion, limb lengthening was possible in this case, especially. You cannot generalize the ideas in this case. Without adverse effects because of the meticulous follow-up. However, careful hip monitoring during lengthening to guard against subluxation is very important. And we told the family, if you are going to have subluxation or dislocation, we're going to do pelvic support osteotomy. Anyhow, there are many secrets for hip stability. We cannot say this hip is stable or unstable. It depends upon which type of hip you've got, depends upon the abnormality. So I don't advise anybody to repeat it again, except if the family know quite well that perhaps you are going to have dislocation or subluxation during lengthening. That's it. Thank you.
Thank you, Gamal. If you can stop sharing, thank you so much. This is a really interesting case. You have shared some important points here. You've been really successful in both your attempts of limb lengthening not all of us have this degree of success. Very often we find that that hip will subluxate or dislocate out while you're doing your lengthening. So I think your point that you brought up of having a repeated surveillance of the hip during the lengthening is a very important takeaway point. As Dr. Johari said, it's time. Sometimes it's always better to, if you're expecting that that hip will create a problem, to do a pelvic procedure beforehand to protect the head from subluxating further. Or if you find that it is subluxating, maybe then span the hip with the fixator during the lengthening process as well. So thank you so much for that wonderful case and your experience in limb lengthening for these difficult problems. We'll take the next case, which is by Timothy Nunn. Tim, if you can share your screen. Thank you so much.
Well, Tim is sharing his screen. Tim is from a Kishor hospital in Ethiopia. Thank you, Tim, for being here.
Lovely, thank you. So my case to discuss is a skeletally mature 17-year-old male farmer who presented at least 2 years following multifocal sepsis, which was managed at a local hospital. The report was that it was managed non-surgically. He comes in with low BMI, so he's very thin looking and undernourished. He additionally has a left same side proximal humeral osteomyelitis process with a draining sinus, and he's from Mother Teresa area. Mother Teresa home in Addis, but his sort of home situation is that he's a rural dweller from a farming community, some distance away from the main town. So he's looking for options. He on examination, he's clearly short, and he presents in a wheelchair. Now, I can get him to stand, and when he stands, he needs a stick or someone to hold on to. So 8 centimeters short. He's fixed in adduction with obvious pelvic obliquity. The hip is posteriorly dislocated and it's painful to move. There's fixed flexion deformity of 40 degrees, and then painfully he'll flex right up to 110. So if I can ask the panel to give their opinion, please. Thank you.
Hey, Rick, since you've worked in Africa before, maybe we could start with you.
Yeah, thank you. So I think one of the things I'd want to look for is just making sure that the infection had initially been cleared. Tim, you mentioned that there was some drainage of a sinus. I missed, was that humerus or femur?
Yeah, that was on the humerus. The femur, there was no sinus. Yeah. Okay. The hip was fine.
So I'd probably, before intervening on the femur, I'd want to make sure that I might do a CT scan of the humerus and deal with any sequestrum that was there, because I think we're looking at a femoral head excision and a pelvic support osteotomy, and any residual drainage in other part, whether using a frame for the pelvic support or double plating. I would want to deal with the underlying infection first, but he's got a painful degenerate joint. So I think the options of managing this one, whether it be a pelvic support osteotomy, I think a hip fusion, you very clearly said he's from a rural area and probably having the ability to squat will be very important to him. So I'd avoid a hip arthrodesis. I think for obvious reasons, a hip arthroplasty represents its own challenges regarding durability and future infection. So a pelvic support osteotomy, possibly with a distal lengthening, and realignment would be the aspect of choice. But it's a challenging case, 8 centimeters short. But hopefully some of that would also be due to the fixed flexion and fixed adduction, and maybe some of that shortening would be less severe after realignment. But yeah, thanks, Tim. We'll be grateful to know what you did.
Great. Maybe we could ask Gamal. Gamal, if you're still on, I know you're probably busy in your clinic.
Yes, you know, I'm living in Africa all my life, so.
Yeah. What are your thoughts?
Yes, it's an ideal candidate for pelvic support. And you have to do, with the pelvic support, you are going to remove the head, and we have to correct the deformity. So you need valgus, and whatever you have, rotational deformity or something, you correct it from the proximal part acutely. And you can continue gradually afterwards. When you put the fixator and you still, after the operation, still have some flexion, or still you need more abduction or rotation, you can continue gradually 1 millimeter per day from the upper part of the pelvic support. And you can continue lengthening, you know, immediately afterwards. And I think this is it's a good option for this guy.
Fantastic. Daria, do you have anything to add to what's been said so far?
It's very difficult question, because when I see these X-rays, at first I will think about endoprothesis, but the infection is very big problem for prothesis, endoprothesis. So maybe we will think about arthrodesis, the hip, because I think that some correction operation maybe will not to do better than we see now.
Dr. Johari.
Kishor, not much to add, you know, from what Rick and Gamal said, you know. I would opt for a pelvic support osteotomy, you know, with resection of the femoral head and lengthening at the same time.
Great. Tim, why don't you show us what you did?
Sure. So the management process, we thought, well, he really needs to gain weight and control the sepsis, as the panelists have said. So he underwent a humeral sacrosterectomy first, and give him nutritional support. We organized some crutches and tried to get him more mobile once the sinus had closed, and then scheduled him for a pelvic support osteotomy. So the first stage, we did this slightly differently. We were conscious that he was a farmer and needed deep knee flexion to maintain his livelihood. So the first stage here, we did a girdlestones resection arthroplasty using a posterior approach. We then put him onto skeletal traction for 10 days. There was no sign of infection of the hip at that time, and there was no active infection. And then he went after 10 days for a proximal valgizing osteotomy, which was plated using a separate lateral approach. This was done, this subtrochanteric area, at the level of the ischial tuberosity. A single plate was put on, and then it was covered with a 90-90 plate configuration to give it additional stability. And you can see the graded trochanter has been lateralized here. We decided to see how he would get on with this without a distal lengthening, knowing that he would inevitably have some knee stiffness in my hands by doing a femoral lengthening. So he went on to crutches after surgery, touch weight bearing for 6 weeks. He then started rehabilitation. and then gradually started increasing weight bearing and was full weight bearing by 3 months and generally improved over the next year in his walking ability. It was never perfect, but it was better than what he was in his wheelchair. I just show you some screening films here that I took for interest of his proximal osteotomy, and you can see here on fluoro I'm flexing and extending, abducting and adducting the hip, and you can see there is a moving center of rotation where the proximal femur is just rolling against the side of the pelvis there. And I've got a short video of him walking. Again, he's got a large shoe raise of about 5 centimeters here. You can see his walking is not it's not normal, but he's certainly not using a walking aid. His Harris hip score improved to 86, so that's not normal, but he was able to squat and stand on one leg, and he returned to his farming profession. So in the end, he wasn't offered a femoral lengthening due to the need for deep knee flexion and squatting, and was managed and continues to be managed with boots with a shoe raise. So this, I just wanted to just flag up, this is what the traditional pelvic support osteotomy or a Lizaroff hip reconstruction would look like, with the distal lengthening and varization achieved here with a hexapod frame. It does inevitably cause some quads tightness and some rehabilitation challenges, which in our setting we wouldn't have been able to surmount. Thank you.
Well, that's a great case, and you know, you can stop screen sharing, and yeah, we can just discuss now. So would anybody do that case any differently? Everybody said pelvic support osteotomy. Rick, Dr. Johari, or Gamal, your preference is a plate, or would you use a frame?
I usually put the fixator because I don't trust myself, because sometimes you feel you did a great job, you corrected the whole deformity or something like this. And when the patient starts walking 2 weeks or 3 weeks afterwards, you find out that you need more valgus.
Yeah.
Perhaps you need more extension, so you correct it gradually. And this is the beauty of doing it gradually. You can change your mind. You can ask the patient he is fine or not. And that's why in almost all my cases, I don't do acute correction of the proximal part.
Fantastic. Well, I think in the interest of time, I think we'll move ahead. It's now my pleasure to introduce Dr. Aroojis is currently the president of the Pediatric Orthopedic Society of India. Al wears many hats, and I think the biggest hat he wears is he truly cares about the world, and his impact is just not in India, as you can see with his leadership, and it's truly impacting globally with what he does, and has been a real partner in crime with me on many things. So Al, looking forward to your case.
Thank you, Kishor. So to carry on to what Tim has presented, again, a similar case of a complete destruction of the capital femoral epiphysis, and hoping to show you a different approach in this case. So here's a 12-year-old boy who had a history of preterm delivery and who stayed in the NICU for some time, developed sepsis of the left hip at day 12, and treated by an arthrotomy and drainage, and now comes to us at the age of 12 with a very unstable hip. As you can see, the amount of shortening that he has no pain, he's got a good range of motion, but you can see when he does a single limb stance, the amount of pelvic dip that this child really undergoes. So again, a similar problem to what Tim showed us. So here's the X-ray. And you can see what's up here is not the femoral head, but the greater trochanter. and the entire epiphysis and the neck have been resolved because of sepsis. Here's another view. So this is a single stance X-ray, and you can see the amount of marked pelvic obliquity and the amount of femoral shortening that this child has on the full-length X-ray. So again, to bring up the problems that this child has, again, what Tim spoke about, not only do they have this severe pelvic obliquity, but also the instability, which is quite disabling to them. As they walk, because of the instability of the hip, they have the vertical telescoping, and the shortening is much more than what you actually measure. They have a very distinct abductor lurch, and of course, the limb length discrepancy. So in the interest of time, we've already discussed this. The options when you have absence of femoral head are limited. So I'll just show you quickly what we did. This is a different type of an approach, and this is an old operation described almost 100 years ago by Colonna, which is called trochanteric arthroplasty. And what we did here is to disinsert the abductors from the greater trochanter, to put the greater trochanter into the acetabulum, and then do a varus osteotomy below that to contain the trochanter even better, and to create some sort of a neck of a trochanteric shaft angle, as it were. At 1 year, you could see that he was less unstable. The hip, the trochanter that was put in has started to remodel a little bit, but you can see that there's gradual subluxation and extrusion from the acetabulum. So he then underwent a Chiari medial displacement osteotomy to improve coverage, and he's now at 8 years follow-up at the age of 20. He's got a fairly good range of motion. There's not much pain. He has a mild lurch. He's able to squat and sit cross-legged. The hip X-ray does look a little funky, but surprisingly, when you look at his gait and his movement, he's doing quite well for himself. So at 8 years, he does not have any pain. He has a very mild lurch. He's able to squat and sit cross-legged, which is an important requirement given his rural status. And I think this did help pull in a few years for him. Going forward with the discussion, we have already talked of the various treatment options when you have a loss of the capital femoral epiphysis. And you could just leave this alone. You could do an arthrodesis. You could do a Schanz angulation osteotomy that Tim showed you, or an elixir of hip reconstruction that Gamal spoke about. And we have found that in selective cases, a trochanteric arthroplasty, as described by Colonna, does have some role to play. This is an initial report published by Weston in 1980, where he had almost 17 children who underwent this procedure, and at a medium-term follow-up, he did manage to achieve good stability and a range of motion in most cases. He found that the greater trochanter remodels to resemble the femoral head. There is a problem of gradual subluxation, and according to him, the best results were in children nearing skeletal maturity. And he did mention that the results are better if you combine it with a simultaneous or a staged femoral varus osteotomy and an acetabuloplasty. And we've had the occasion to do this in about 8 patients in our institution. This is one of the cases, again, where you can see that the greater trochanter has remodeled really well to almost resemble the femoral head. And this is where a child where we had done a relocation of the trochanter, we had done a varus osteotomy and an acetabuloplasty as well. There's been a more recent paper from Perry Schoenecker with a smaller number of patients, but with a longer follow-up. And contrastingly, in his series, the children were much younger, and he felt that the optimum age of surgery would probably be in a younger child to allow for better remodeling of the transferred distal greater trochanter. But again, found that the results are better if you do a simultaneous or a staged femoral osteotomy. So I do propose that this is one of the options. We use this very judiciously. Loss of the femoral epiphysis is a common presentation in our setup, but we don't use this operation very often. I think when we have a fairly good acetabulum, that is the time when we prefer to offer trochanteric arthroplasty rather than an elixir of hip reconstruction or a Schanz osteotomy. We do find that it improves the gait, there's less abductor lurch, More importantly, it abolishes that vertical telescoping and instability. It lessens the limb length discrepancy and provides a stable fulcrum for future limb length procedures. I have to admit that it's often a hit and miss procedure. We've had a few patients where they have become stiff or had gradual subluxation. So we're extremely judicious when to offer this procedure for children who have a complete loss of the epiphysis. So thank you very much for your attention. If there are any questions from the panel or any suggestions, I'll be happy to take them. Thank you.
Alaric, I just want to say, I think that's fascinating and you know, real improvement on the natural history. I think many of us were thinking pelvic support osteotomy. I've always thought the trochanteric arthroplasty was really an operation for the younger, but you've shown that it can be successfully used in the older as well. So thank you for showing us that.
Thank you. Thanks, Rick. We have a couple of minutes for some questions that came up in the group chat. So I think this one's for Rick. When you showed your case of hip dislocation and you have an acetabulum where there is a lot of fibrous tissue, how would you manage the acetabulum, the various adhesions that are present within the hip joint? And the next question follow-up to that is, what would be the post-op recommendation after you've done your reduction in terms of a spica cast versus an abduction brace? And when do you start ranging these hips out? So Rick, over to you, followed by Dr. Johari.
No, thank you. It's a great question. The approach is, of course, just standard Smith-Peterson approach, coming over the top of the capsule. Psoas is very stuck on capsule for these open hip reductions. Peeling that off carefully, releasing, doing a musculotendinous recession of psoas over the brim, opening up the capsule, and the capsule is entirely obliterated as mentioned. And then what do you do for that? What I've tended to do is to take 15 blade and just take a knife and just start to carve out some of the initial part of all that scarring, because you need to get into it first. And going as far as that without going as far as, of course, the articular cartilage, but making that initial hollow with a knife and then coming in there with a fine rongeur and pick. And it's tedious work. And you might spend 20 minutes just gradually picking out the scar as you get closer and closer. The scar tissue, unfortunately, does seem to be embedded up against the articular cartilage. And so you just have to be very patient, working your way through. It's a time to put on a few songs and be patient and pick down just to actually clear the acetabulum. And then once you've done that, you'll be able to reduce the femoral head. So it's a patient part of the operation. I don't know if there's a quicker or better way. I've often found it being entirely adherent. And then for post-operatively, I routinely put these children in a spica. I think for some of these children, they got a lot of flattening of the medial femoral head. That ossific nucleus is sitting very laterally. And then sometimes you'll have some of them wanting to decenter. I haven't taken to doing a transarticular wire. I've enjoyed more taking a threaded wire through the trochanter into the lateral table of the ilium. So an extra-articular GT to ilial wire in a case that hip just wants to decenter, but I know many would do a transarticular, and I've seen that working well as well. I'd only do that if it wanted to decenter and it felt like I was concerned about some subluxation in my spica. But either way, at 6 weeks, I'll take the spica off. I do an EUA on the table. Ideally, leave out of the spica at 6 weeks. If it needed a bit more, maybe a few weeks in a Petri cast. But I haven't typically done abduction bracing after that.
Thanks, Rick. That was really clear. Dr. Johari, you've got a lot of experience with these post-septic hip dislocations. Do you have anything to add, any more tips and tricks to what Rick has wonderfully explained?
No, I think hip spica is a must. You can't take that lightly, because there can be a lot of incongruity between the femoral head and the acetabulum. Despite your reconstruction, that can happen, and it's good to stabilize the femoral head in the acetabulum for at least 6 weeks. So that would be the only thing additional.
Great. Thank you so much. And there's one question which I presume will be for Gamal. When you do a limb lengthening, what do you prefer, a proximal or a distal lengthening, and why?
Usually in these cases, it depends upon the distance. Perhaps if you do it in the distal part, I think I've heard to Rick talking about he was afraid to do lengthening because of in the distal part because the knee flexion. And I agree with him entirely that because one of my patients, he was a farmer and he wants to improve. He had flexion 120 degrees, but he wants more than 120 degrees. Some people need. So I prefer to do it in the distal part of the femur, but sometimes bifocal also. Upper and middle part, it depends upon the distance. And when I do it in the distal part, it's not very distal because I want to get away from the knee. So it's not that distal because I don't want to put wires or half pins closer to the knee to avoid the knee stiffness.
Thank you. Thanks, Gamal. We are almost close to time now, so I just come up with a few conclusions that came out from these cases. Sequelae are common following neonatal hip joint sepsis. Ayesha showed us wonderfully that ossification of the capital epiphysis is frequently delayed following sepsis, and a close observation is mandated. We have also seen from Dr. Johari and from Daria that coxa, vara, and Pseudarthrosis of the femoral neck can be treated with a valgus osteotomy and fixation, with or without some bone grafting. Rick has shown us nicely that a post-septic dislocation can be treated by open reduction, a femoral osteotomy, and arthroplasty. But as he has rightly said, you must be able to pick the winners. Not every patient who has a dislocation needs a reconstruction to be done. You have to pick your patients very judiciously. Gamal has shown us some excellent cases with AVN and growth arrest, which is a difficult problem, and how limb lengthening can help in such cases. And then Tim and I have shown cases of complete loss of the capital epiphysis, managed in different ways, either with a Schanz pelvic osteotomy or trochanteric arthroplasty or an Elisdorf hip reconstruction. So I'm really grateful to my co-moderator, Kishor Mulpuri, all our faculty who have come in from various parts of the world. I'm very grateful to SICOT Pioneer for giving us this platform to conduct our very first webinar of the Pediatrics SICOT Committee on this important topic. Before we leave, I would request all of you attending live to fill out the post-webinar survey. If you point your cameras towards this QR code, you'll be able to take your survey, which will enable you to receive a personalized certificate of attendance. Don't forget to join us for our next SICOT events, which is the SICOT Bios Orthopedic Education 360, a global view, which is scheduled for the 7th of March, Friday at these timings. And the next webinar the next event, which is the SICOT Shoulder Arthroscopy Cadaver course, which will be conducted at Arthro Lab, Singapore, Monday and Tuesday, 28th and 29th of April, 2025. Of course, we have the SICOT virtual diploma exam with a diplomate ceremony. Encourage all your young trainees, residents, and fellows to apply for the online diploma exam, scheduled for the 10th of April. And these are the dates which are put up here on the slide. So to conclude, I would say thank you very much, and I welcome all of you to attend the 45th SICOT Orthopedic World Congress, which will be held in Madrid, Spain, on the 3rd and 5th of from the 3rd to the 5th of September. The abstract submission is now open. The deadline is coming up soon, so I would urge all of you to send in your abstracts and attend this Congress, which really is going to be a great one. Thank you very much, all our panelists, for joining in. And it was a great event. I think we covered a whole lot of cases. It's been wonderful having all of you here. Thank you very much and have a great weekend.
Thank you, Al. Thank you, Kishor. And thank you all the others.
Bye. Thank you.
Bye. Bye.